meaning in R and so forth. So, let me start with some of the equipment. Turn in your agenda to, and the page is number 21, if you can make that out. And 21 is the Pleuro-Vac. And that insert is in your, and you don't have to read it all, and it's too small a print, but that insert is in the Pleuro-Vac. When it comes packaged up, the Pleuro-Vac, that insert is in there. And I told you the next page, which would be, you know, some of them are upside down. So it's 20, that was 21. Page 22 was the one, Dr. Orcutt, I told you was so simplified. Has anybody read it? Yeah. Well, that he uses the bottles, and I think I told you that. His article, because it was 1972, he uses bottles in his description. Well, your bottles are right here. This is, the blue is one bottle, the red is another bottle, and this, the drainage is the third bottle. So it's exactly like Dr. Orcutt's article, but these are your bottles. And we have different types of Pleuro-Vacs, but they all basically are the same in what they're doing. So they're put in because you've got a leak. You've got a pneumothorax, hemothorax, spontaneous, or whatever, but you've got a leak. And the balloons have deflated. At least, praise the Lord, we've got 3 balloons on one side and 2 on the other, so when we get a leak, they don't all go. Just one lobe goes. And that's where we get the chest tube. So the physician's going to put the chest tube in. And when it's magic. I don't know how somebody came up with it. Somebody just realized that if they put a tube, you know, in the old days I probably would have thought of a leak in the lung, that lobe's gone. But somebody realized you could put a tube in that deflated, and if I put a different pressure at the end of the tube, it'll start going back up. And I think it was really great thinking. So the physician is putting the tube in, and this will be, that's all right, just leave it. This is going to be what makes that pressure different out here and in there, which makes it start coming back up. So the physician is putting it in, and you go to the supply closet and get the Pleuro-Vac. And what you've got to do, now the directions are there, but do you really have time to put your glasses on and sit down and read it? Not really when the physician's putting in this, because that's usually what happens. They say, run get a Pleuro-Vac, I'm going to put a chest tube in. And so I'm telling you what that paper says, which is just simply take it out of its cover, and back here in the back, taped is usually a funnel. Of course, it's gone now, but it's a funnel. If not a funnel, a catheter tip syringe you can go get. When I say catheter tip, it would fit this, not a needle type lure lock. Won't fit the end. So if you don't have a funnel, this one got away without a funnel, go get a 50 milliliter catheter tip syringe. And here's all you do, get a Sharpie, and here it's 0, write the date. 1 today, 1/26/20, and the time, 1400 or whatever, and put that at the 0. You've taken care of that bottle. Now, this bottle, if you can see on your little insert, I don't know whether you can read it, but it says right here, fill, F-I-L-L, fill to here. Now, let's say I hadn't got time to hunt down a 50 milliliter syringe. This didn't come with a funnel, so I'm just going to get a syringe saline, sterile water in it and stick it in this little hole and shoot water to here. I can do it that way, or I can do the way it was intended, which was put you sterile water in a syringe, catheter tip, and push slowly, because if you do too much, you can't tell if it's too much. Oh, it's too full. Then just take a syringe and aspirate it to that line. My little motto is, if it was all right to be more or less, they wouldn't have put a line to say fill to here. So they want it to here. They know what the pressure inside, outside needs to be, and it depends on that water level there. So use your syringe here, or use the catheter tip here, and it's just like this, flubbing in the breeze. Put your syringe on, shoot your, and I like sterile water, because if it's sterile saline, it'll start leaving a residue of, like salt leaves. Doesn't hurt anything because it's sterile, but it's cloudy. Now I shouldn't have any water here, because it goes over to here. So fill to here. Now, that's the second bottle, and that's the water seal. That's our sealer. And I'm telling you more than I know, but that's called the water seal. And our final bottle is the suction bottle. The physician says, I don't want any suction. Oh, okay. So, if that's the case, the physician just gets that chest tube in the patient, and you've filled your water to here. We're not using the suction. You're going to use gravity. And you hand the physician the end of this. See, it comes like this. And the physician puts it on the chest tube, you tape it, and that's it. The big rule is this needs to stay below the lungs, below the heart. So if it's at the foot of the bed, use your handles, put it at the foot of the bed. Now, Mr. Joe Blow can go walk all he wants to. Walk down the hall. It's not a magic thing. That's the reason Dr. Orcutt wrote that article. It's not a scary thing. Look what you did. You wrote down 126:20, and you filled to here. Now, that's not hard to do, but you do want to nurse it. He's asked for gravity, which means we're not going to be pushing. So every time you're in his room, this patient's room, and you see collection from his lungs in here, just raise it up and help it. Drain it. That's all you need to do. Just help the gravity. At 7 tonight, when you go off duty, get out on your knees or whenever. I think we do I's and O's still old time, 7 to 3, 3 to 11, 11 to 7. So you, at 3 o'clock this afternoon, you get on your knees and you draw a line how much you have, and that's your drainage from the lungs. Now, and then 11 tonight, they'll do the same. The physician tomorrow morning says, it's not draining. I still hear, they still got a leak. I can tell they're not draining like they're still full. So let's put some suction on. So what they do then is, so this is to the patient. You hold that. So that's to the patient, and he wants suction now. Now this that was flooded in the breeze is going to get an adapter and go to the wall suction. And you can do the little wheel for suction as high as you want to, because the physician's going to order how much suction, and you just dial it right here with this little dial. Just twist it to whatever amount of suction the doctor wants. And that's all you do now, and it bubbles now. And that's why they would rather us use still water. With that bubbling, it makes it kind of cloud. Doesn't hurt anything. It's just... So now we're using it. We'll never empty it. We just mark accurately. But it needs to stay upright at all times, and it needs to be below our chest. You go walk. Now let's say on suction, now I can't walk them. Oh yes, you can, and please do. We don't want them to get weaker, but they're attached to suction. They were unattached when they were on gravity. So for the few minutes, and for what it's worth to have exercise, undo the suction and go for your walk. Just keep it down. There's nothing magic. Not going to put a medial spinal push, ain't going to happen. You had them for a whole day on gravity. So still walk them, even though they're attached to the wall. We fell over. And now my column of fluid is in all three. Well, it doesn't need to be thrown away. Just get down and mark it and do some improvising of how much and just kind of start back over. But make a line that when it comes over there, don't count that. But it's just a big bunch of plastic to throw away when it doesn't need to be. That does happen, that it falls over and then all the fluid goes in all of them. Any questions on the Pleuro-Vac? They're all, as I said, the same, just a little different, but see, this one's the same. There's your suction, there's your water seal to here, and here is your, I see drainage. This is your drainage, water seal, suction. So they're a little different, but basically they're the same. So that's the Pleuro-Vac. And as I said, you've got that insert if you wanted to look at it, but that's what's included with the package. And then read Dr. Orcutt's article on the three and kind of put that in front of you, and you see his three bottles and what they're doing for magic that it seals the lungs with this pressure that's negative outside to inside, makes the lungs. And of course, the lungs adhere around the chest tube and kind of seal, and then starts building up and blowing back up. One little thing, so you don't get embarrassed. I kept seeing one day bubbles like carbonation. The patient was on a chest tube, and when I was down marking my amount, I saw bubbles. So I told the doctor, and he made me feel foolish. He says, yeah, the patient's got a leak. Oh, yeah, that's right. But the deal is, as long as there's bubbles, the leak is still there. When it's no more, it shouldn't be leaking, shouldn't be bubbling. But they also bring out, this isn't perfect. It may not have fit perfect at the factory, and it still has some air leakage, this thing. So a little idea, if you want, so to speak, is clamp off your tubing to the chest tube. And when it's clamped off and stop your suction, if you still have bubbles, it probably is a little bit faulty. If no bubbles, then we know you still have a leak. Just use your sense. I wanted to say one more thing on getting a specimen. The physician says, I think there's an infection involved, or there's something, let's see. And so you want to get a specimen, and on the tubing to the Pleuro-Vac, you have that spot to do it. And so you can put a syringe, a needle, and aspirate some of the fluid. And if you need to clamp it a minute to collect fluid right there, get it there, because you can't get it out of here. See, that drainage is not any place for you to stick a needle and get it. So just clamp it right here, let it collect right in there, and then aspirate your specimen for a culture or whatever. And let's see, there was one more thing on here I wanted to say. Oh, about changing it. Now, we don't empty it. We throw them away. So how long is it going to take? I don't know. However long, how much secretions we're pulling off. Normally, a person keeps this about 3 days. Takes about that long to seal that leak. But we still have to a lot of times change them. And so when it's getting close, and I promise you it'll be right up here when you come on duty, and they'll let you change it. And it's not hard. You know what to do. Go to the storeroom, get one of these, put the time, put fill to here, and then you just clamp it, and take it apart, not up here where the chest is, just take it apart at one of the sections and put your UA on. So it's real simple, but nurses always let it usually be the next shift. All right, that was the Pleuro-Vac. And now go to your briefs and turn to the respiratory page. In the briefs, respiratory is on page 24, I believe. And you can kind of check as we go over the equipment. All right, I just want to say the canister on the wall, the liners are disposable. Just the liner. They'd rather not replace all this because it doesn't need to be replaced and it's so expensive. It's a lot of plastic to go in the landfill. But the liner, we can replace. Now, I ask that you never go by these numbers for serious charting. You need to empty into a hard container. Remember, always empty significant secretions in a hard container. You say, well, this is hard. Yeah, but it's not accurate because we've got something that can get big, small. So when you change this at your 3 p.m., 11 p.m., 6 in the morning, when you do that, go in the bathroom, take out this, pour, rinse it, and put it back. We don't get another one. That's expensive and not necessary. If you look at the top of this, it helps you. It tells you patient. So this is what goes to the patient. This goes to the vacuum. And that's it. And that's on the wall. So patient and vacuum. Now, then why did they put these on here if we can't use them? It's just for glancing. When I was in here, it was at 100. It's up to 500, and I was just in here an hour ago. That's wise. You don't chart that. What you chart is anytime you want to, go take it out, measure it. The accurate measurement has to be in a hard container. And you may have seen people put tape right here. It's not accurate. It's just not, I had somebody do a research to see the difference on a mount. 6 o'clock it was here, 3 o'clock it was here. And then we added up what they had charted, and it wasn't the same as when they don't empty it. They just mark it, and it was not the same. So it's not a good habit. It is easier to mark a tape here, but it's not as accurate. So empty it when I know time is right to empty it. Rinse it and put it back in here. And we try not to ever throw away this or that. So this does get actually, because the filter is not clean. this we never throw away. Make sure, it seems a silly thing to say, well, one time I was in a room setting it up, and this, when we turned the suction on, started that. And I just have to say we're hooked up on it. And the tech came through and she said, have you got 2 of these together? No, we just got 1. Well, she gets her fingernails, pries it apart, and we had 2 of them. So if it ever does that, it's probably because you didn't know because you put 2 in there. Didn't know it. Didn't mean to. So that's your canister that's collecting. Now, the incentive spirometer. In the old days, we did blow bottles because we thought they were good. They realized they were rupturing a villi, so they said this is better for people to hold it in their mouth, empty their lungs, empty it, put this in the mouth, and fill up your lungs, and this goes up. A great nurse puts it where they saw it. What puts this thing where they saw it go to. So then the next time we say, you got to at least do 3,000. And that's just for you to put and remember. And they're great for telling the family, but make sure they do them right. Some of them just kind of watch TV. They need to be taught how to do it, and that's empty the lungs and then do that, and then mark it. So that's instead of stronger. I wish we didn't have to buy them. They're a lot of plastic that we put in the landfill, and technically we shouldn't have to if we were good nurses. And that is, you just assess your patient and then go to the end of the bed and say, now listen to me, breathe with me. Fill your lungs as full as you can and hold it. And let it out and push it out. Hold it, let it out, and push it out. It does as good as those. And I told a physician that one time, and he said, you're right, but nurses don't do it. And we don't. We just get so tied up with so many other things to do. And yet, deep breathing is so important. When I first got out of school, I worked at night with a nurse, an older nurse, and I remember telling her so-and-so had a temp. It was like midnight. She said, have you deep breathed them? Oh, no. Not at midnight, no. And she said, go in there and deep breathe them. Do it again at 2 o'clock. It was down. The patient needed deep breathing. It's just not a stressful. The importance. They lay in bed and just shallow breathe. So you be one of those. The best thing is to ask family. They don't have to do that every hour. But tell the family, would you just remind him, do it with him. It's good for you too. Because the only time, I think I've told you, the only time we deep breathe is running steps or running a hall or voluntarily, like I'm doing now. Okay. Now, when we did the chest tube, the physician put in the chest tube and we put the Pleuro-Vac on. Well, the physician knew they had drainage and needed to go back. But if it's just a pneuma, air, thorax, they just got air leaking. And there's no secretions involved. And so then the physician might put a Heimlich, like the Heimlich maneuver, a Heimlich chest tube in. And it looks just like that. They have a new one, but nobody's seen them. I've seen them in books, but I've never seen them out, and nobody else I've talked to have either. So still, I think these are plentiful, the Heimlich chest tube. And they're put in only if you've got a leak that doesn't have secretion, because this is open. This is open, and we don't want secretions pouring out that. That's kind of a Penrose drain in there. So the air comes out through the Penrose and out. the humerus and put a glove on. And I don't have any problem with it because it's not going to go back in, but they think it's cute to see the glove blow up during the day, you know, with air coming out. And that's fine, it doesn't hurt anything, and air isn't going to go back through the pinrose. I did take care of a patient one time, and he was a DNR, do not resuscitate, and he was in the unit, and we couldn't get an IV in him, and so it meant a central line. The family said that's heroic. They didn't want us to put a central line because we couldn't do a peripheral. So we said the only way he can stay in ICU is to have IV access. Nobody stays in ICU without IV access. He can't stay in here unless we do central line for the physician. So they reluctantly agreed to let the central line be in. He had cancer of the lungs. So the physician put the central line in, and when he did, which no fault of his, sometimes the apex of the lung is high, and he nicked the lung. So now the patient has a pneumothorax. Now, a family comes in to visit, and we got this thing. I thought you said it was just a central line. Look at all this. So the physician put in a Heimlich, and the man had a lot of secretions. But they weren't going to do Pleuro-Vac. They weren't going to do that kind of stuff. So the physician put this because it could be under the covers, you know, and this didn't show. Now, he told the family, of course, he had to, that he just made a little nick, but that's no problem. We've taken care of that. Well, I have the man as a patient, and I'm turning him every 2 hours. And so he had the Heimlich in, and when I turned him, it's always glue. So when I turned him, he just poured out over my bed, the secretions in his lungs. So that it just took one time. The next time I put a towel when I turned him, and the towel absorbed everything. It was okay. It's just not put in if you think you're going to have secretions. The Heimlich is here. Now, this is a good one. This is your Pleuro-X is what's listed on page 24 in your briefs. The Pleuro-X. And it's for when the lungs are full but they don't have a leak. You know, we know what to do about leaks and secretions. But this is, the lungs are fine as far as no leak. They're loaded with fluid. And usually it's cancer that have, you know, because if you've got diseased or cancer in your lungs, they just start secretion. The body tries to fight. And so secretions are put out. So actually this was invented by a physician here several years, I want to say 10 years ago, maybe even more. And he was pulmonary, which is interesting, and very fit and defined and young. And he ends up with cancer of the lungs. Well, he wanted to work as long as he could. So, but he'd fill up. And he's, you know, trying to stay here and work, and he can't breathe very good. So he came up with this Pleuro-X, or the Denver pump is also called. And here, and I'm going to tell you, I'm getting ready to show you how to do it. And wherever you are tomorrow, if somebody said, do you know how to work the Denver pump, or Pleuro-X, Pleuro-Vac, vacuum, Pleuro-X, I want you to say yes. And here's what you do. Husbands do it. It's not hard. You just have to know what it's doing. They have made an incision into the pleura of the patient, and it's covered and sterile, but it has the matching tube. And so if they're at home, their spouse can do it. let's say they came here, they wouldn't come into the hospital because they're full. That's what Dr. Rodriguez was trying to cut out, so everybody doesn't have to come from McMinnville and every place around just to have their lungs drained. It's a thoracotomy. It's a portable thoracotomy when you take out fluid. So he thought if I just had a way that we could take out my fluid at home. And so he came up with it. I don't know why it's called the Denver pump. They must have gotten a grant or something out of Denver. Anyway, so let's say you came in because for whatever reason that wasn't related to your lungs, and it's time, you can tell yourself when they're loaded, or the family say, I think I need drainage. And so you order the Pleuro-Vac, and these come in little bags, sterile. And this is, of course, covered, the end is covered because it's a sterile deal. And nothing's in it. And so you're ready to do it. That comes separate. Then you have a tray, a Pleuro-Vac tray. And I just want you to hear the words. You use it as it's layered. So just don't go digging and scratching around. Use it as it's layered. So you open it, and it has some swabs for you to take off the bandage of the patient. Take it off. They want the clean area. And here's your tube ready to match your tube. And it has a cap on it. And so, and yours has a cap here. Now, go on and clamp it. I like to clamp anything when I'm in transition. I just think it stops everything. It's not dripping, it's not draining. So I'm going to put a clamp on this. I've got the next thing, sterile gloves. They're on that tray. Put on my sterile gloves, and I want to take off the cap on this tube, take off this cap, and you attach them. Now nothing's happening because I'm clamped. So I sit here and I'm going to unclamp, and it starts filling because it's vacuum. And it's filling, sometimes it really is filling fast, the pressure. You know, if they were really full, the pressure is big. And there was a sister that would come in here. They didn't do it at the mother house. She'd come in for her thoracotomy or her Pleuro-Vac treatment. And she is the only one that ever asked us to go real slow. She said it hurts to, you know. So if you need to go slow, just put your little bit of clamp, and let it drain. How much? Well, this is 500, and it's kind of the same concept as kidneys. You know, when you catheterize somebody, they say, don't take more than 1,000, it's too much of shock on the body. Well, this is kind of the same way, but I don't know if any of you all have ever catheterized anybody and taken more than 1,000. But you do it slow and gingerly and with mindful thoughts. I'm getting high here. It just says it shocks the body to lose fluid so fast. And they say the same with this. But I'm here to tell you, I filled 3 of these at one time. And it's because the family say, now that's not enough, you need to do another one. So clamp, get another one. He knows he's doing it at home. He said, I never quit it unless it's 1,500. So he does about 3 of them. So you just have to be mindful that it can be shocking, but do it slow. If they still can't breathe well, then do another one. When you're through, of course, clamp it, take it apart. The tray has another cap for you here. You're going to throw this away at biohazard. You put the cap back on. It gives you a dressing and opaque to cover it. I'd mark always the time and date that it was disturbed, and you're fine. So couldn't you do it now? It's not hard, and that's the changing of Pleuro-Vacs. And if you go to home health, they do them a lot. You can always YouTube and probably read about it and how to do it too. That's the beautiful thing. You go to your car and read about it. Now, let's see, I think I'll do, I could do, let me do the board. Your basic apparatuses that we breathe by. And so the granddaddy of all is the nasal cannula, just the cannula. And remember the little prongs go back and not up. So put them there around the ears and they'll deliver. The thing is, you've got this tube attached to your oxygen on the wall. And this is your very basic oxygen. And you and I are breathing 21% oxygen, 21. This, for every liter, and you know that beats and you roll the wheel to go liters of oxygen. Every liter is 4% more oxygen. So the physician says put them on 2 liters of oxygen. Well, you know now they're getting 20 out here and 4. So they're breathing 28% oxygen. The research says that they can breathe 5 liters of oxygen without water, humidifier. Once it's higher than 5 liters, they say it dries us too much out. So for several years they dropped back and weren't humidifying oxygen. But the hospital's so dry anyway, it was a mess. And you had more crusty, bleedy mucous membranes. It wasn't worth it. So pretty much everybody is getting humidified oxygen, even if it's 2 to 3 liters. So, this delivers 1 to 6 liters. That's about all that tubing can handle, is 1 to 6 liters. So 6 times 4 is 24. So 20 out here, 24 through the wall oxygen. They're getting about 44% oxygen with the cannula. Well, that cannula is rubbing the nares right here, and it's sore and raw. And I don't know whether you've heard it, but it drives me crazy how scared everybody is for Vaseline because it's an oil base, and that oil is flammable. So one of the hospitals won't even let you have Vaseline in the hospital because it's oil based and they're afraid to get it around oxygen. Come on. I tell people I have never in 52 years of nursing seen the headlines say hospital exploded because Vaseline was used for nares with oxygen. Now, so I tell people, I just love Vaseline. Put a little on your, rub it very thin, but it's such a great barrier. Now, we've got fancy barriers for excoriated rectums and everything, but it's Vaseline glorified, and it's costly. Vaseline's cheap. So I see nothing wrong with just a little coat of it there, and then your nares, promise. Now, but let's say, okay, I can try a mask if you want to. So that's our next one, is the mask delivering the same thing, only I just don't have the prongs. And I don't think I have a paper on it. So we could go, but I'm telling you, I don't think I've ever known a patient that when I've gone to the mask, they don't want that. They don't want that claustrophobic mask. They'd rather have the prong. All right, so those are 2. Then this is the Ventura. And so you know we can deliver 44% oxygen with those 2. The Ventura is a wonderful, if break you want to look, it's real hard to read. But this tells you what liters and what percent it will make it. And the word is, it's the absolute most accurate in delivering oxygen. The physician says, I want them to have 4 liters at such and such percent. That's what it says on this adapter. So you put the adapter in your Ventura, and then the bag of these other adapters taped to the wall, because tomorrow the physician may want to up it. You've got your adapter, put it here, the Ventura, where it's more accurate. It can, I always have to look it up. The Ventura can deliver, what does it say on there? 30 to 60% plus room air. So we're doing pretty good. Okay? So there's the Ventura. Now, anytime you go in a room and they have a mask like this with a bag, it's a rebreather. We're getting close to a ventilator now. We're progressing. But there's 2 kinds of rebreathers, the partial rebreather and the non-rebreather. And I can, if you were, this one isn't accurate, but I'm going to tell you, you go visit a friend and you walk in the room and they look like this. Well, I see you've got a rebreather. Now, they may not know whether it's a partial or a non. You can get up and examine if you want to, and you can't on this one because this is just to give you the idea. It's been, but it makes, if you'll give your common sense. On the sides are a diaphragm, 2 little holes. If they're flaps, you exhale and the flap opens and lets your air out and flap back down. No way you're going to rebreathe any air. So that's as easy as it gets. If it's kind of open, or they are open, you exhale and inhale and you get some of this oxygen and some rebreathe. So you're partially rebreathing. So partial rebreathe, you're getting, this says 45 to 70% oxygen. Add your room to it too. So partial rebreathe is a good thing. But the thing just before they have to go to a ventilator is a non-rebreather. And you can imagine why, because it's closed off and making you breathe oxygen. No rebreathing of any air. No rebreathing. So the non-rebreather will deliver up to 70 to 100%. So just slip over and visit with your friend and look at the diaphragm on the side, and you'll know if it's a partial or a non. And you'll know how sick they are. If they're on a non, they are really not perfusing oxygen so well. So now, the physician is not pleased with the O2 sat, not pleased with the arterial blood gases, so we've just got to get them on a ventilator. So they're put on a ventilator. The E-tube has to be put in, or if they have a trach, that has to be put in. But they got the E-tube. And those are strong things, aren't they? So, let's say that is in the E-tube. Really, and that's the one thing, nurses can do it, but we're not doing it like we used to. Several years ago, many years ago, when I took ACLS, this was part of our, part of passing ACLS, adult cardiac life support. And you have to do it every 2 years. I still have to do it every 2 years, but we don't pass E-tubes anymore. not because we couldn't, but nurses can, but they really leave it up to respiratory and the physicians. And so they're put down, and and let me just say, they're blown up with a syringe, and if the cuff seals it in. Now we're going to go on and put tape around it or Velcro and hold it in, but this seals it so that when air is pushed in, it doesn't go to the end and come back out. It goes to the lungs, or the bronchioles and lungs. So if this is flat out here, the cuff is flat, the ball is flat. If that's big and puffy, then this is big and puffy because we can't see it. So the E2 is now in, and if this patient was fairly conscious, then we may have to sedate him because his reflex is to get it out. So now the physician has him on a ventilator, respirator ventilator. And we're going to talk about this later. All right, so you have your ventilator, respirator, or whatever, and the physician has told you what knobs to put on what. And I'm going to tell you the different ones, and they make sense. FiO2, fractured, inspired O2. Well, that means a portion of inspired oxygen. And here's what I want. The physician says 40%. Well, you just go to the dashboard of the respirator and turn it to 40. That's how easy it is. You say, well, I thought respiratory does it. Hey, they do, but they may not be there at the moment we're doing it, and it's, hey, let's turn a switch to 40. FiO2, 40. Then the physician, on this dashboard, it says rate. And the physician wants the patient breathing on his own. They're not doing so good. I mean, they do it all right, but the physician says, I really want them to breathe more than they're doing, at least 8 minutes. And this patient isn't doing 8 a minute. So I know because there's a spot on the dashboard that says rate, and it's the here and now. 6. The physician wants 8. So you find another spot on the respirator, and it says MDI, mandatory inspired respiration, MIR. It's mandatory though. I'm not getting the right letters, but it's mandatory, and the machine, the physician said I want 8. And the mandatory tells you that the machine is made to make him breathe at least 8. And if you were charting him every hour, you look at his rate, oh, it's 10, he's breathing 10. But 8 are mandatory, and so he's breathing 2 on his own. And you chart it as MDI, mandatory, oh, I said it wrong, but anyway, whatever it's under, the mandatory part, and mandatory 8/10. So people know 8/10, he's mandatory is 8, he's breathing 10. So then the physician knows he's at least breathing a little on his own. And then the next one is oh, I love this one. Now, I was going to tell you all. I love MDI. Let's see. I'll get them in a minute. CPAP, continuous pressure what is it, CPAP? It's continuous positive pressure. What?
Continuous
CPAP, continuous positive.
Airway pressure.
What? Airway pressure, positive airway pressure, CPAP. And you know you have to be a conscious individual. I mean, can't be comatose. You can sleep with them. But you have to be breathing on your own spontaneously. And if you're doing better. And so if the patient, if the doctor now has written CPAP, then they'll be off the mandatory. And then there's one more synchronized, SMIV. Synchronized mandatory inspired ventilation. SMIV. Synchronized, and that means that if they're not doing evenly, the machine makes them, squeezes in a breath. Now, I love the CPAP. Not CPAP. PEEP. P-E-E-P. Positive expired end pressure. Positive expired end, E-N-D, pressure. And here's what somebody discovered. Now here's their villi, and the ventilator pushes air in, and the villi opens, pushes good oxygen diffused, and then the ventilator lets off, and that's what you and I are doing. We take a deep breath, it opens, perfuses, we exhale, and we go back down. If you've got a disease or sticky villi, the ventilator pushes in, opens, and then you exhale and it comes back down. But the next time, it may be so sticky, it can't get in. So the physician realizes that and puts them on PEEP. And you're pretty sick if you're on PEEP. So what it does, I think it's so clever. The air comes in, blows up their villi, and then leaves some of the air in so that it doesn't come back and stick. Isn't that clever? So PEEP, they're pretty sick because the physician's scared that we can't get it open again. So let's keep it kind of quasi-open. Isn't that clever? So the physician orders PEEP. Let me see now. Okay. Now, before we'll take a break, but before we do, I want to go over one more thing, and that is that, oh yeah, more than one. I went on left this Ballard, or it's just like that, laying in the bed with him. He does have a cap on it, but it's just laying in the bed. Now, hopefully respiratory mood changes all this out every 24 because of Pseudomonas, the water bug. Because as sterile as it is, Pseudomonas gets in there and in 24 hours starts growing. And so, and two more dials on your respiratory dash are high pressure alarm, and that is just what it says. The lungs and the tubing is under high pressure. And why is it? Because its pressure has increased in this tube. Why? Because probably you've got either a kink and the pressure's building up, or we've got, the pressure's building up, or I don't have it on here, but water condenses so in here. And the water filled up this little curve right here. It can't get through, air can't get through. So it's high pressure because it can't get through. The pressure keeps going higher and higher to try to get through. But the water has collected. And in the old days, I waste can. Nowadays, they have a little bag you can, if you'll just aim it, the water will go in the bag. So your high pressure is on. So go over and look for where in the core, in the tubing, is there building up high pressure. First off, silence the thing. Just push that silence button and look for where the high pressure is. Is it kink or is it filled with water? The other dashboard thing is low pressure. Well, it's just what it says. The pressure's not going through. My part, it's undone. It's when I look close, it isn't undone from the machine. So the pressure's so low. Just push it back in. So those are two of the deals on the items on the dash. And then the Ballard is the suctioning. And I'm going to go over suction in this, and then we'll break a minute and let's go over suctioning, just old tiny suction. So the physician, this is changed out every 24, so it's not going to grow a lot of stuff. But this is sterile in there, and I'm going to use it all day to suction. And if I want to, because he's so thick, I can open this little sidebar and squeeze saline in there and push a button on the dash that says 100% oxygen. And then that gives him 100% oxygen that's been humidified. So there is that. I'm ready to suction him. And the biggest thing is his mouth, he could cough. So you don't want to be in his line of cough. So I'm ready to go down, and I tell him I'm going to suction him. So I just go down, and it's going nicely. It may give me a little problem just as it goes out of the E-tube. And he's fine with me going down, because he can still breathe around, blew his nose. He's not hypoxic till I start pulling oxygen off of him. And so this is locked. You have to turn it, and then it can now be suction. The thought is that they lay on it in bed, so they lock it. I'm ready now, and now I'm going to tell him. And I may have hit the gag reflex right here, and he's coughing. That's fine. Don't come out because he's coughing. He's red-faced. Just go. And you want to take 12 seconds. Don't count. He'll probably slap you. Just. And now he's calmer, but he's coughing. That's exactly what I wanted. I wanted him to cough up here. I can see some mucus in here. Just go right there and suction right there. Get all that mucus that he coughed in here. Probably coughed out. I'm going to push the button for 100% oxygen. Now, what you didn't know I was doing, this is usually clearer. I looked at how much was coming out. It's in the canister, but it's a whole day's worth in there. The day's worth. So it's not accurate. But I'll tell you, this was full. And this is like 5 tuberculin syringes. So if that was full, I'm going to say to myself, well, that was thick and it was yellow. And it's about 5 milliliters. And it's in the canister. I'm letting him have 100% oxygen and calm down. I'm going to go again. And I did so good, that's why I'm going again. If I didn't do very good. But I'm going on down. He's not coughing yet. Probably till it comes out of the E-tube. And now I'm ready again. I'm not just jerking it. I want it to be good. He's coughing. Do I want to put a little more humidifying? I can if I want to. So I may put a little bit, push 100% oxygen. Let's rest a minute. How much did I get that time? About half as much. So I'm going to say 2 more milliliters. My limit is 3. I'm still productive. As long as I'm in it, I'm going to go my 3rd time. Sometimes if you don't get anything, the next time don't. It's fairly traumatic. They become hypoxic. When I'm doing that, they're losing and I want to do it one more time since we've done so good. So I'll do it one more time, give him a minute, do it a third time, and the same experience. Now one time, 100% oxygen, I got about 2 again, that's enough. So I got, what, about 5 and 2 and 2, about approximately 10 milliliters of thick. Give the color, the thickness, or the consistency, and the best to your ability, the amount that you got out. That's it. I'm going to take the tubing off of this, put it up on the wall again, put the cap on this, and lock it. And if Fluffy lays in bed with it. Now, this all, let's see, there was something else I wanted to say on. Well, I do want to tell you this. The physician wants to know if anything's growing in the mucous membranes. So he says, let's get a specimen. So, I'm going to, neither one. It's the Lukens tube, you see here. Mucus collection device with a suction trap. I have this. I have a better one. Let me see if I can find it. I have a better Lukens tube. Well, I may find it later. But the point is, now this tubing goes to my suction. And so when I was doing suction, it lands in here. And you do it gently, you don't do it, because I want to collect some specimen here. When I've got enough in here before it goes to the canister, I stop, take it off, and it goes to the, just in this container. I have a better Lukens tube that I'll look for in a minute. But it's for collecting mucus trap, they call it. But that's called the Ballard, or the closed system drainage. Yeah. If you'll turn that off. On the dashboard is IMV, intermittent mandatory ventilation. IMV, intermittent mandatory ventilation. Intermittent, IMV. And then SIMV is synchronized intermittent mandatory ventilation. Synchronized intermittent mandatory ventilation. IMV, I think that's CPAP we talked about, continuous positive air pressure. Patient has to be breathing on their own for a CPAP. That's what people use at home when they snore and to keep them from being apneic. All right, that I wanted to say, and then I wanted just to, Yonkers, remember? Mm-hmm. The Yonkers, you know, and call it by its name. The other mucus trap, Lukens, that would go into the tube, and it's collected, the trap. So it's just another mucus trap or Lukens tube to collect your specimen, and when you collect it, put the cap on it and it goes to the lab like that, the Lukens tube. If you have any mask or apparatus that has something that looks like it holds medicine, it probably does, and you wouldn't be doing it, not even nurses. Inhalation therapy will do it, but I just want you to know the medicine's put in there for their breathing.
Doesn't the respiratory therapist does that?
Uh-huh. Yeah. Yeah. And then the metered dose, metered dose in installation or know, you put the puffer of on this end. And I don't know many people that, oh, I'm sorry, this is, you know, the puff things people use. They got, if the physician wants a meter dose inhaler, this is what it is. It goes here instead of your mouth. And then I wish people did them right, but I don't worry about it. I've got bigger worries than trying to teach them. So often they watch TV and just go, you know, and it's just in their mouth and they swallow the medicine. And I say to myself, maybe it's doing some good. But they put it in their mouth and tell them to empty their lungs. And then now, when I push this, make a big breath. And stop. Still in, a lot of it's still here. Let it out and bring it. They got a little to work on. So the biggest thing is emptying your lungs and squeezing the puffer at the same time that you inhale. I mean, it's just a technique that not many I see do well. So I'm not sure I put a lot of weight on inhalers, but then I hadn't had any problem either. I just have to mention, you know, nursing, mouth care is nursing, and, you know, they've got an E-tube with tape all around, they're on the ventilator, and people take these sponges and put them underwater and call it mouth care. And I told there's a nurse up here, and I said something, and she said, she overheard me talking to a student on mouth care, and I said, Piola, tomorrow morning, take one of these home, and when you wake up from bed, do it and see if that's enough mouth care for you. Well, of course it is. That is not mouth care. So what you just invent anything to clean people's mouths when they're occupied with tubes or any, and it might be even a tongue blade with a washcloth and Cepacol on it. And get over there and rub those gums and try to, here's the tube, try to get the tongue, rub the tongue, change your cloth and do it over here. I'm going to tell you, comatose will try to open and let you do it. They want their mouth clean. We get them sometimes from the unit, and I'm not dissing the unit, I'm just saying they think they've got bigger fish to fry, but they come to us, and if you look in with a flashlight, you can see it's coated back there, and we'll grab hold and can put just a clump of dried mucus from air breathing from a tube. Well, all the mucus around it is dried. And you pull out that, it helps a lot of breathing. So I just can't emphasize mouth care. And you're a new man, you woman, when your mouth's clean. So I just want to say, this is not mouth care. I love them after your mouth's been cleaned. I think it's great to clean a person. And that's whether they've got an E-tube in or not, just good cleaning of gums and tongue. And then end with this. It tastes good and makes refreshments. Now, I think what we lack on this demonstration part is the suction in the trache. And so the most simple on suction, and we've already done suctioning with the E-tube, but this is the cheapest, and it comes with a cannula or catheter and a little dish to put your water or saline in, or whatever you're using. So we open it, and we sure don't take this with our hands. And if I have some gloves handy, I'm going to put them on. This probably isn't going to be sterile this minute. I mean, in real life. Let's say I'm real life, and I'm getting ready to suction this patient because I'm getting ready to take the tubing, the suction apparatus, and I'm going to put it right here and turn on the suction. Now, it may be an E-tube, it may be a trache, but let's say that we've got to suction an E-tube. And so they're not even on, we won't put them on a ventilator, they're just got their E tube. And I want to suction with that little cup. So I'm gonna pick it up, I'm not sterile, I'm gonna pick it up. The inside is sterile, and I wanna keep that sterile. I just put it there, I pour my saline or my water in, but I'm gonna save my cannula for sterile. So now I'm gonna put on sterile gloves. And I pick this up because I'm sterile, and I'm gonna wrap it around my, and the tubing that I turned on and put right here is running. I just pick it up and push it in here. I've lost sterility with my left hand, that's fine. And there's my hole for the vacuum that I'll put my finger over, but I don't want to put it over as I go down, remember? We don't want them hypoxic as I go down. So I am going to give a little water to lubricate inside. So I go. Now don't stand there and take your whole cup of water now. I ain't got any more. Just enough to lubricate inside. I don't need any more ointment, but I'm ready now to go down the E tube. And so my hand's sterile. I go down just like I did. Hold that, Sharon. No, it's up high. So I just do the same I did with the Ballard. And now he's coughing and it's spewing. So now I am going to put my finger over and I go, and now I touch it all I want to because I'm sterile. And I'm sterile for him. And he's coughing, so I'm going to clear this out. I saw how many. Did y'all look? See, I have that one. I'm going to give him a second. But he's coughed, so I'm going to do this right in here and get some of that mucus that's right there. Okay, I'm going to give you a second. Catch your breath. Now go down again. Do the same thing we did with the Ballard. As soon as I come out, just give him a second. I don't think I'm going to do him a third time, but I got about 5 total. Charted, thickness, consistency, color, amount. And of course, if I need a specimen, I put it on there and the tubing there for the lubricant. I'm through with this. We don't have any. I have to throw it all away. And now I got to keep the Ballard for 24 hours, but that was because it was covered in plastic. So that's the cheapest of all. And now, what do we use in a nursing home? They've got the budget, the nursing homes. They've gone to all of them to a kit that when I open it, they've got the cannula, but they've already got my water ready for me. And so, let me open it with regular gloves. My tubing's here, turn it on, suction. And I need to open this, so that cannula's in there with that. Open that, and now put my sterile gloves on, pick this up. I'm going to lose sterility with the hand. I'm going down with my right hand. So I'll lose sterility with the left hand. So that's just a little more high price kit for suctioning. Now, yeah, that's all right, now, one thing I do want to tell you, I was watching, we had a patient, we were suctioning, student, and the respiratory ran in and did it before we did, and that's fine. But he did, you know how I was going, and he did straight through, he never intermittent. So I learned you could do it either way. So I said to him, talk to me, tell me why you do, he's respiratory, he must know more. And I said, tell me why you do it in one firm swoosh rather than intermittent. I said, I know you can do both, but is there a reason you, he said, no, probably you're doing it better than I am. He said, I just get tired of doing it the same way every time. So I'm just saying you can do either. I think if I were going to kick a ball down a long hall, I get better results if I kick it along the way than one time. I don't know if that analogy's any good, but that's what I'm going to use. So either way. Now, let's go to the trach. And technically, they would like for the E-tube, now I say this, so I'm stating you, they don't like an E-tube to stay longer than 3 weeks. It's irritant, it's irritating, you know, rubbing, and that we're supposed to, sometimes we used to deflate the bulb every 12 hours, every 24, so it wouldn't keep rubbing and cause a fistula. Now they say the material's such it doesn't cause a fistula, and we don't have to do that. So we don't have to deflate, reflate, but they don't want us to keep them in forever. Well, they need help, so they've got to have some help, and so we go to the trach. And so we take the trach, and it'll be, of course, it has to be inserted, and we now have disposable inner cannulas, but we in the hospital don't use them. Nursing homes, without the money, and use them. You just squeeze, take it out, throw it away, put a new one in. That's real easy. But it's expensive. Now I do notice nursing homes throw one away in the morning, and life's busy, busy, busy. At night, the night shifts, so often they'll clean them, like we're getting ready to clean. Even though it's disposable, they'll only buy one a day. So mostly I've noticed that in nursing homes. Now I thought I had one more tray. Maybe not. The trach cuff is the same story. If it's inflated and snug, air is going down and not coming up. It'll come out your nose or out the E-tube, the trach tube. Now, if I suction, I do the same way. I tell you what I've noticed through the years. It doesn't make any sense, but for whatever reason, the patients always seem to suction better when I leave the cannula in and suction, rather than during cleaning of it and suction. And I don't know why, but actually it was a tech. We had this cleaning over here in the dish, and we were trying to suction, and it'd get hung up. I don't know why, but it would get, and this tech saw us doing it. She said, I just never suction if I don't have the cannula in. She said, if you can get past that, whatever, that's fine, but I just find it never gets caught if you keep that in. So we would just suction just like we did. But now I'm ready to clean this cannula. And if you're at this hospital, I think it's morning and night, use it real. And cannulas, we don't throw them away. Nursing home, maybe we clean it just once. So the cleaning has not changed a lot. The three layered baskets. Are y'all familiar? Or stainless steel? They're stacked. They come to you, and inside is all you need: gloves, pipe cleaner, suction tube, and brushes. And so that might be stacks, and unsterilely, I hadn't put sterile, you just take them apart. 2 are empty, and 1 has all your supplies. So I've got 3 of these. You see the 3? This container came with all three together, but they can come stacked. So I've got all three out here. One is holding all the supplies, and the other two are empty. So now my two empty, I'm gonna put saline in one, or still water, whichever. And then peroxide or Heimlich in the other one. A cleanser, not it's not gonna, they say it's bacterial static. We try to keep bacteria down. It's not kind of an antibiotic solution. So you use hexaphene or whatever, Heimlich or, what was the other one I said?
Peroxide?
Yeah, peroxide or Heimlich. So now, I've got the solutions in the back, in the cups. And here is his tray. And I just suctioned him. We just got through suctioning. So now I'm gonna clean this in a cannula. Anchor, he's got it tied or Velcroed. Hold it, because when you wiggle it, it's gonna make it talk. And I like for it to talk, because he's bringing, but I don't want it in my face. So yes, I put it aside, but still hold it. Unlock it. Back. Now, I've got my two solutions. I want to put it in my cleaning solution, Heimlich or peroxide. Now, here's what I did. I learned I was the first to do that. No, I never understood why people dropped it in the sink, in the solution, when the outside was dirty and it picked up everything. And now I put it in a cleanser that's not really going to kill. It cleans, but it doesn't kill. And that always was wearisome to me, that I even thought of E. coli. You know, they're down there adjusting stuff, and then they're watching TV and touch this. I got E. coli on there, and now it's going to be inside. Well, now they just said don't do that, which I thought at the time, this is odd that we're dropping it. What would I do? I leaned it up against the side of the, it fell. Well, if it falls, that's what it does. But leave it up and keep the unsterile out. And let it be kind of cooking. And while it's cooking, now I'm unsterile. And I'm going to stay unsterile. I don't need this sterile gloves. I'm going to stay unsterile. And I'm going to pick up, oh, and it fell in the little thing. That's okay. It's not like I got, let's say it fell, oh, it fell on the floor. Okay, that's all right too. Not all right, but we're not going to call the doctor to put a new one in. You take what fell on the floor, go to the bathroom, and you clean it good with the hand soap and hot water, because, you know, that's hand soap, it's pretty caustic. So clean it up good. And now I'm going to do it again. And I picked these up. They're sterile. They were in here. My hand is not sterile. I told you I'm using non-sterile this time. Non-sterile. And I'm doing only the one end that's unsterile. So I'm going to lay them here. And I do need to, I've got some 4x4s in here too. And they're not sterile either. I'm going to take one of those and just clean, kind of a parachute, all the corners. Clean around this trach, mucus stuff. Clean that. Now, so I'm ready now to pick this up by its unsterile end. That I want to keep as sterile as I can. Now, I said that, and I just dropped it on the floor. But I'm telling you, that's just the thing again. I cleaned it best I could, and I'm calling it sterile again. They really kind of call them clean, but we try to say sterile. So pick your pipe cleaner up. Dip it in your peroxide, always from the bottom, and there's mucus in there. And I am unsterile here, touching, so I cannot push it through. Do you know that mucus is just riding with me? No good. I mean, that's all right, but it's worthless. I'm fortunate because I know that this brush does fit. So often brushes don't. Put it in the box. Again, start from the bottom. Now that mucus is pushing up, and it's all up in there. Well, this isn't sterile anyway, so I'm gonna get a Q-tip by the end, that's sterile, and just clean that mucus right there, because that's, you know, it's just common sense. I'm trying my best to keep this as sterile as possible. Really, that's all I need, because my brush works so good. So now I want to rinse it in the saline, and then hold it and insert it and lock it. And that's it. Now, I have done it when that mucus, the brush doesn't work, and the mucus is so thick that I think I'll do sterile. I did him this morning. It was awful. I want to do it sterile this time. So here's what I do. Everything's the same. I take the cannula out. I put it here to be boiling. And now I'm going to put my sterile gloves on sterilely. They don't have to be double layered, but let's say I put them on. I'm now sterile. Let's say I've got sterile gloves. I am picking this up and I lost sterility. Just because, you know, that's dirty. This is sterile. So I want to pick up my pipe cleaner anywhere I want to pick it up. A minute ago I had to, dropped it. Anywhere a minute ago I had to just touch the end. But the whole thing's sterile and my hand's sterile. So I'm going to put it in thick mucus. But because I'm sterile, I can push it completely through. Take my sterile hand and touch that and bring it out. Go back, don't pick up a Q-tip now and do it again because you're dirty. Dirty to dirty, sterile to sterile. Q-tips all the way up. I'm going to put it in, push it all the way through. So why do that? Only if you didn't have a good brush. Then tonight when I do it, I don't think that I need to do it sterile. Go back. It was good. Rinse, put it back in. That's, oh, now what? Here, important, I may have already mentioned it last week. Never cut, this came this way, already sewed. Never cut a 4x4 because the little filaments will go into the wound. They may close off and start festering. This never, those little fragments will go into the tray. So this comes ready for you. Put it around that tray. Now, let's say you accidentally got one wet, or it's no good. Just fold two of them and put them around the tray. And then, of course, in there is the ribbons. They're still doing ribbons. They have done ribbons for 50 years, I've been doing. But they also do Velcro. They don't put them in the kits, but you can order a Velcro tie. Any questions on, and as I said, equipment's a little better. And babe, if you'll,
One of the most popular questions I get is about eating breakfast. Some people prefer to skip it or don't feel hungry in the morning. Others love eating breakfast and say it's their favorite food of the day. So is the claim that breakfast is the most important meal of the day true or not?
supposedly our lungs are the only organs that are outside our body, because they really are. They are just absolutely connected to the outside, and none of our other organs are. We have the 3 lobes. We talk about how wonderful to have the 3 lobes on the right and 2 on the left, and that if something's injured, we still got 4 more lobes. You know that our trach is about 4 inches long, and then it branches to the lobes. And the lobes consist of those cells that are alveoli, that when air gets in them, they do the exchange. They exchange the oxygen for the carbon dioxide. And then when the carbon dioxide comes in, they're put out. They breathe it out. And our bodies collected that waste. Praise the Lord, the lungs get rid of that waste CO2. Just a miracle. We need a pint of fluid a day just to keep our respiratory system moist. And that's what I think, people don't realize how important fluids are, because a pint is used just for that. And then, people say, when we talk about blood gases in a minute, it's, you know, we love oxygen, but CO2 keeps us breathing, because when that gets low, it triggers us to take a breath, and so consequently, we've got baroreceptors that when our blood pressure goes down, baroreceptors are receptors in our brain that make us take breaths more often. And then I wanted to tell you a little bit more, I think, just so fascinating about the lungs. If you took the surface of these 3 lobes and the 2 lobes, open them up, spread them out, the surface area equals a half a tennis court. Now, is that an unbelievable amount of surface area? Surface area in the lungs, we spread it out, it'd be a half a tennis court. When germs and virus, we have, and we already know this, but the cilia are lining our lobes inside. You know, at the base of the alveoli, we've got a cilia, a hair that is moving, and its primary job is just to keep us clean. And it moves like that wave in football. Remember that wave that would go through the stadium, a wave? And that's, our cilia start at the bottom and do that wave, working dust, pollen, everything up and out. And I think it's so fascinating that they work 100% of the time at night when we sleep as much as daytime. Our blood vessels, they cut down about 90% at night as far as activity, but our cilia stay busy. How fast, and I just memorize it because it's just fascinating to me. 931 times a minute they're moving per cilia. That's 12 times a second that they're moving. Pulmonary taunting, trying to keep our lungs, because it's like they're outside, and the body is trying best to keep us clean, so that that exchange of oxygen and carbon dioxide doesn't get betrayed. A man who was teaching, I went to some of his lectures, and he was teaching about cilia air, and he said 3 puffs of a cigarette paralyzes those cilia. 3 puffs inhaled paralyze them, and they wake back up after the person's finished the cigarette. And I later asked him, I heard him speak 3 times. I asked him, I said, well, how quick do they wake back up? And he said, you know, we can't pinpoint it because it depends on the heaviness of the nicotine and the inhalation of the tobacco. And so he said, we don't really, and then when did you like the next one? The cigarette, or whatever. And so, but they wake back up. Now the bad part is, but then they paralyze them with the next cigarette, or cigar, or pipe, or whatever, that's inhaled. Now, the malady, the problem is the tar that's in tobacco, because the tar begins to build up at the base of the cilia, and they can still do this. They can still wave for a long time, years, but then pretty soon they're buried. And so, but the body is so compensatory that there's another mechanism, and that is that we secrete. If we can't keep our lungs clean with this, the body knows that and makes us secrete more that drips, and the dripping in the respiratory system, because of the heavy secretion, makes us cough. And the coughing is the pulmonary toiletry. Isn't that amazing? So that's your smoker's cough. The smoker has destroyed that cleaning, so now the drip makes the smoker cough. I think that's so wonderful how the body tries its best. I heard a physician one time said the body wants to be normal so bad, it'll do anything to try to stay normal. And that is keep our lungs clean. Now, it takes you and I about 3% of our energy to breathe. You're not even thinking about it, and I'm not either. But if your lungs are abused, then it will take as much as 30%, 33% to be exact, of your energy to breathe. And if you notice, a person who really has COPD or chronic pulmonary problems, they're not obese because they keep their calories just stay down with the energy. They're staying active enough, but their breathing is taking a third of their energy. So,
May I ask you something this relative? What causes interstitial lung disease?
Interstitial what?
Lung disease.
Interstitial what?
Interstitial lung disease.
Oh, what causes interstitial lung disease? I don't know. I really,
Because they're not, most of them, they're not smokers. They're not smokers.
they don't smoke, they just have the disease. I don't know. Isn't it crazy, so many things we can get? And there's just not enough written about it, I don't think. COPD, the chronic obstructive pulmonary disease, it can be just that, pulmonary problems, but it could be emphysema, it could be congestive heart failure. But the point is, it's chronic pulmonary, obstructive pulmonary disease problems. We just aren't exchanging the gases properly. And if it's emphysema, what do they say? Your energy is pushing air out. It's not hard to breathe in, but it doesn't automatically expel. And you have to push it out, and consequently you get the barrel because you're using those muscles to push your air out. Congestive heart failure, we'll just speak to that a minute, because obviously the heart's our culprit, and it's just not pumping good enough. Praise the Lord, we've got those meds we just went over that kind of help that contraction. But if you're dyspneic, a little air hungry, that heart probably is not pushing the airflow through those lungs, because the lungs having a problem because you're air hungry or you're having dyspnea. So yeah, it's the heart, but it's affecting the lungs. And so you go to the doctor, I can't breathe, I don't know what's going on. They check you and say, well, your heart's your issue. you're getting congested in your lungs because the heart can't beat so good, is not as proficient. So I'm going to put you on digoxin. You'll make that kind of the first choice. Make those contractions great. And in doing that, I'm going to give you a diuretic, cut some of the fluid down, so the heart doesn't have to work so hard. So a cardiac patient with dyspnea usually just starts on a great cardiac drug and a diuretic. And that can last a while. Now they'll come back every 6 months or whatever, but they may have to have a higher dose of their diuretic and their lanoxin. And they can do that a while. Dyspnea is the first sign of congestive heart failure. But then the doctor looks at them this time. It's been about 2 years you've been my patient. And you know, they always look at your ankles. You're swollen. And he wasn't swollen 6 months ago. That means the heart you've got heart disease. Your heart, well, you had it anyway, but it's worsened. Because now the muscle, even on the medicines, can't get the fluid from the feet back. It's settling down there. The pump just didn't. Yours and mine, who don't have swollen legs, our pump is getting it back and going again. But if it's settling down there, that pump is losing some of it. So the physician puts them on another drug that helps that pumping, helps that another cardiogenic. Maybe we're on 2 now, cardiogenic drugs, trying to help that contraction. And then they're gonna put you on a higher diuretic to try to clear all that fluid, because you're collecting fluid, and we need to get the fluid out so your heart can maybe beat a little better. And then, and I think I brought it up last week, I think I did, turn in your briefs to medicines. And that I want to say, what page is medicine in the briefs? 16, but it's not on 16. Go to about 22 in the briefs. Keep going. Go to the last page, and that is on page 22. Go up high, and you see Zeroxylin. Zeroxylin. And did I mention it last week? You don't have it marked, so I must not have. Zeroxylin is wonderful. It's sad, but it's wonderful. Zeroxylin enhances diuretics. You never get Zeroxylin by itself, but it's the last resort. The physician has got you on high Lasix, got you on high cardiac drug, and you're just you're not improving a lot. So then the physician orders Zeroxylin, and that is a miracle. You just go down, but it doesn't last forever. But it's a drug that will enhance, and they don't usually use it until I don't mean the end of your life, but kind of the end of your treatment. And after you can still live a while, of course, but I'm just telling. One physician I know, he took a congestive heart patient and just fluid restriction down to hardly any fluid, cardiac drug really down. I mean, dehydrated, and then let him do anything he wanted to. And his hope was the heart would be jarred and start beating a little better. And it did for about 10 more months. All kinds of ways. All right, now let me see if there's anything else I want to say. I think that's what I want to say right there. Now, we've been over the ventilator. Breath sounds, I want to say. You can say rails and rhonchi, but we're not using them much anymore because it's hard for people to get in mind too. I'd always have to breathe myself if I tried to teach it, because it's hard to remember bronchi and rales. They'd like for us now just to say wheezy, which is dry, and then crackles that are wet, and then friction rub, and you can tell if something's rough, like it's rubbing. And then the word audible air passage. Well, we don't like to say normal or within normal limits, so we just say audible air passage, or when you're breathing normal. I think we all know apnea, A, is always without, P-N-E-A, no breathing. And then Brady, nypnea, pranipnea, slow breathing, Brady. I do want to mention chain stoking, C-H-E-Y-N-E, hyphen Stokes. It usually means, it doesn't have to mean death, but it's serious. And it's crescendo. They're apneic. You think they're gone. And then they start out barely, and a little more, and it's a crescendo, and it gets high, and then they start slowing down, and they go apneic again. And so it's I think it's an interesting definition. It's regular, irregular, because that isn't great breathing, but it is regular. They don't just do it shorter next time, or fact, it's pretty regular. And a lot of times there's a death rattle in it too. But it doesn't always mean you're about to die. Dyspnea, we already know, difficulty. I want you to be familiar with Kussmaul, K-U-S-S-M-E-U-L. That way. Kussmaul, breathing. And I want you to think Kussmaul, K-U-S-S-M-O-M-A-U-L, Kussmaul, equals metabolic acidosis equals diabetes. So when diabetics are in their diabetic coma, they're in metabolic acidosis, and they Kussmaul. Deep, rapid, and unlabored breathing. Deep, rapid, and unlabored. Of course, tachypnea is tachypnea. T-A-C-H-Y-P-N-E-A. And Apparatus is the Rice Krispie. It's air in our tissue. Now, just a bit on the colors of sputum. We all want colorless. Green is usually Pseudomonas. And Pseudomonas is our water bug that is in shower heads, water that sits around 24 hours. They say any water that sits around 24 hours probably has Pseudomonas in it. Even sterile. Green mucus, sputum that's green probably has Pseudomonas. Creamy is probably staph. Creamy yellow. Rusty looking, kind of rusty, might be pneumococcal. Frothy, y'all have always heard if they're frothy around their mouth, it's pulmonary edema. And I don't know, I think you can tell brown from rusty. Brown is probably old blood. If you're having to wonder, it's either, if you think, is this rusty or brown? And of course, I think you can tell if you're bleeding. Klebsiella, K-L-E-B, as in boy, S-I-E-L-L-A, Klebsiella. Now, I want to go over blood gases. Our last 15 minutes, let's do blood gases. And what I want you to know on blood gases, all I want you to know is the blood pH should be a 7. 0.4, I'm sorry, 7.4. And do you realize that's a little bit basic? Because 7 is neutral. And anything under 7 in anything is acidic. Anything above 7 is basic or alkalytic. So our blood is just a touch basic, 7.4. So I want you to know that. I want you to know that our blood, to be good, the CO2, the carbon dioxide in there, that's the waste, should only be 35 to 45. And then our bloods by carb, HCO3 by carb, 22 to 26. Now, go on and write O2, PO2, that's just partial oxygen. O2, our arterial blood should be 80 to 100. You probably already knew that. We don't really need that to read our blood gases. So, with those norms, and you can always look them up, but those are all you need to make an intelligent blood gas analysis. And so what we're going to do is, I'm going to give you some blood gases, and we're going to decide what state they're in and what needs to be done about it. So, the pH of someone's blood is 7.24. The PCO2 is 83. And the HCO3, or the bicarb, is 24. Now here are the 3 things I need to know. I need to know, number 1, is this patient acidotic or alkalotic? Well, if 7.4 is normal, and they're at 7.24, they're acidotic. That's number 1 I need. So I know this patient's acidotic. Number 2, is it respiratory or is it metabolic? Those are my choices. And here's the deal on the 2. Respiratory, remember I told you we get rid of the waste, the CO2? And so that's a beautiful thing, but our respiratory system takes care of that. But if in 3 days, I say it's biblical, if 3 days it can't do it, it asks the kidneys to help. And so in 3 days, if I can't get my blood back, respiratory throw off, then the kidneys automatically are asked to try to help it. And then it becomes metabolic. Is that wonderful or not? Then it becomes that. So what is this patient? Well, I got to decide if it's respiratory or metabolic. And then I'll know how serious. If it's respiratory, it's not quite as serious as metabolic because it hadn't been going on 3 days. So here's the deal. They say you could use the word ROME, R-O-M-E. It's respiratory, or if the pH and the CO2 are opposites. One's up and one's down. That's what I mean by opposites. R-O for Rome. Respiratory is down from 7.4, so it's down. PCO2 is up from the norm, 35 to 45, it's 85, 83. So I have the opposite. So it's respiratory. RO. I can quit right now because this patient is in respiratory acidosis. If that wasn't true, let me go on to the ME. It's metabolic if they both are doing the same thing. They both went down, they both went up. When I say both, pH and CO2, PCO2. Or if one stays in range, they're not opposites. They're really not equal, they're just not cooperating. If one stays in range, they're not opposites, so it's called metabolic. So this patient is in respiratory acidosis, not metabolic. And the third question, I wanted to know if it was acidic or alkalotic. I wanted to know if it's metabolic or respiratory. And my last final thing is, are they okay themselves, or do I need help? In other words, are they fully compensating? Is he blowing off? Is he taking care of his kidneys and lungs? Are they getting rid of the waste? That's fully. And I know it's fully compensated. He's doing fine. Leave him alone. If it's 7.45 is pH. And this patient is not 7.45, is it? It's 7.24. So he is not fully compensating. Let's go to the next one. He's partially compensating if all three are out of range. Well, we know pH is out of range, or we would have made them fully. So PCO2 is out of range, and HCO3 is out of range, isn't it? So all three are out of range, which means they're all three trying to help each other. So they're partially compensating. They may need a little help from the medical community. And our last choice is uncompensated. He flat needs help because he's not compensating at all. And that's when either PCO2 or HCO3 stay in range. They're not budging. One of them. Did one of these, 22 to 24, HCO3 stayed in range. So I always describe it as, it's a bully. He's going to do what he wants to do. He doesn't care if you're dying. He's going to stay in range. Thank you very much. So you're uncompensated. This patient is in respiratory acidosis, uncompensated. Okay, let's take another one. pH is 7.58. PCO2 is 48. HCO3 is 36. Now don't jump ahead. Take them exactly like I did. Is this patient acidotic or alkalotic? They're alkalotic. So they're alkalotic, number one. Number two, are they respiratory or metabolic alkalotic? Wrong. Respiratories are opposite. 7.58 is up from 7.4, but PCO2 is 48, and it was 35 to 45, it's up. So ME, metabolic, they're equally doing the same. They're not respiratory. So this patient is metabolic alkalosis. Are you with me? Now, are they compensating? That's the big thing. All right, is he fully 7.45? No, he isn't. He's not fully. But are all three out of range? Yes. So he's partial. Isn't that wonderful? Let's do one more, and then we're going to talk about what we're going to do about it real quick. One more. 7.36 pH, PCO2 30, HCO3 15. Now what I failed to tell you is that when you and I were looking at all this, there wasn't a range for pH. I told you 7.4, and that's what I want you to keep in mind. But when you're looking at fully compensated, that fully compensated does not need to be exactly 7.45. They say that one can be 7.35 to 7.45 per foot. For the compensation only, not for metabolic, not for anything else. I heard a lecture and she said on this deciding if they're acidotic or alkalotic, she said 7.39 is acidotic. It's exactly like you're partially pregnant or not. You are in acidosis if you're 7.39. You can't say, well, she's a little bit. No, she's acidotic. But for the fully compensated, I can look at the range. Okay. Did you get them? 7.36, PCO2, 30, and HCO3, 15. Okay, are they acidotic or alkalotic? Acidotic. 7.36 is below 7.4. Are they wrong? RO. Are they respiratory? Are both of them opposite? Is 7.36 is down? PCO2 was 35 to 45, wasn't it? And they were down, so they weren't opposite. It means it's metabolic. So this patient is in metabolic acidosis. Are they fully compensated? Yeah, because it's 7.36. That's the only time you look at the pH range. Now, our last 5 minutes, let's go with what do we do about this if they're in it. So I told you, fully, please leave them alone. Partial, we need to do it. And yeah, you did. So let's take respiratory acidosis. Respiratory acidosis. With respiratory acidosis, they're not exchanging. So it's things like pneumothorax. We just don't have enough perfusion. And that's your COPDs, your emphysema, your cardiac arrest, congestive heart. That's, just think about it. If they're not breathing well, they're not moving gases, they're just not exchanging gases proficiently. And so the treatment is a ventilator, a respirator. We've got to have a ventilator push through that pneumonia, push through pneumothorax. We got to have something push, so we need a ventilator. Metabolic acidosis. Now that's like diarrhea, starvation. There's where your diabetes. Anybody that's having diabetic issues, they're bordering on metabolic acidosis. So of course we can work with the diabetic on that. But if it's diarrhea, starvation, electrolytes gone, the treatment's bicarb. And then respiratory alkalosis. Respiratory alkalosis. And if you'll just think of scared, not breathing very deep. You're just fever, pain, scared. People don't breathe very deep. Shallow breathing. This is respiratory alkalosis. The treatment is calm them down, give them a bag to breathe through, calm down, instruct them to slow, deep breaths. And metabolic alkalosis is again, electrolytes are depleted. Might be an NG tube. We're just pulling, they're constant, and maybe diarrhea again with this one. Metabolic alkalosis. And the treatment is Sodium chloride or KCl? I think that will just about get us for respiratory. Do you have any questions? We covered a lot, didn't we? Yeah, I think that's it. All right, next time.